everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Kimani Hendricks, Multimedia Communications Coordinator for MS Focus, and today we're joined by Dr. Ben Thrower, whose topic is Returning to Normal. Are you ready? I am. A COVID-19 and MS update. After the presentation, we will leave time for your questions and comments. Now I'm delighted to introduce our speaker. Dr. Ben Thrower is the Medical Director of the Andrew C. Carlos MS Institute at the Shepherd Center. He previously served as the Medical Director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the Senior Medical Advisor for the Multiple Sclerosis Foundation and enjoys contributing to their quarterly Focus magazine. And as always, we're pleased to have him join us to present this important topic. Dr. Thrower, thanks for being with us today, and I'll turn it over to you.
Great. Thank you, Kimani, and thank you to everyone behind the scenes at MS Focus. As always, you guys do an amazing job. Thank you to all of our sponsors who make these get-togethers possible. So it seems like we've been having this COVID conversation forever now. And, I know all of us are looking forward to getting back to normal. And it does feel like we're moving one step closer, but I think it's still, we still have COVID out there. And so I think it is good to kind of circle back to it, talk a little bit about, what we know about COVID and multiple sclerosis. So I'm going to touch on really three areas, kind of COVID and MS in general, vaccinations and some of the nuances there, talk about just health in the COVID era, and as we're coming hopefully out of this era, and we'll leave plenty of time for questions towards the end, or comments towards the end. So, when we started these discussions during the beginning of the COVID pandemic, we never dealt with this before. So we really didn't know what COVID meant for people with multiple sclerosis. And fortunately, we know a little bit more now. So we know that people with MS in general are not at higher risk for contracting COVID and don't seem to be behaving in general differently than the general population if they do contract COVID. I would say from our standpoint of personal experience, we take care of about 3,000 individuals with multiple sclerosis. To the best of our knowledge, we've had about 120 individuals contract COVID. Unfortunately, we've had three deaths, 5 hospitalizations total. 2 of the 3 deaths were significantly older individuals with some other health problems. One was in a 57-year-old gentleman who didn't have any other health problems. He contracted COVID in January of 2021. Prior to being able to get vaccinated, and went into the intensive care unit and just never really recovered from that. The majority of our folks with MS who've contracted COVID have had, I would say, mild to moderate symptoms, no hospitalizations. Some people have been nearly asymptomatic with their COVID cases. The only reason they knew they had contracted COVID is they had antibody testing done either for a trip or for a medical procedure, and their COVID antibodies came back positive, and otherwise, or not antibodies, so the COVID antigen testing came back positive, and otherwise they would never have known they had contracted COVID. So in general, again, people with MS don't seem to be at higher risk for contracting it, and in general don't seem to be behaving differently. Obviously, if you have other health issues, diabetes, hypertension, obesity, asthma, COPD, that risk may change a little bit if you've got those other health issues. The vaccination story has also been very interesting over time. So messenger RNA technology. So all 3 of our vaccines that we have available to us in the United States, Pfizer, Moderna, Johnson & Johnson, are messenger RNA technology. It was relatively new. We've never had messenger RNA vaccines for anything. That doesn't mean that the technology wasn't there. It's just that we fortunately didn't have a pandemic that required us to use it. Some of the early concerns that we've heard from the MS community, and really people in general were concerns over how quickly the technology seemed to roll out, concerns about long-term safety, and then questions about how long does the immunity last. And I think these are all valid questions. The technology, again, is not really brand new. It has been there for quite a bit. How did we roll these vaccines out so quickly, whereas other vaccines seem to have taken much longer to develop? Part of the answer to that lies in the technology itself. Every other vaccine prior to messenger RNA technology required that you culture the virus itself. So the virus was the vaccine, whether it was live attenuated, killed virus, you had to grow a lot of the virus to make the vaccine. That's not true with messenger RNA technology. You're skipping that step, and that takes a lot of the time out of that fact. So you not having to culture the virus really sped this up pretty dramatically and let us get these vaccines out to people. The lack of long-term safety data, I think that's a valid criticism. So do we have 5-year safety data with these vaccines? We do not. When I was thinking about vaccination for myself, or my wife, who's a physician, was thinking about it for herself, or we started thinking about our staff or the individuals that we take care of, one of the things that made me very comfortable with the lack of long-term safety data was the messenger RNA itself. Messenger RNA is a blueprint. It's a map for a protein. In the case of these vaccines, it's a blueprint for the COVID spike protein. So your body sees that messenger RNA, it makes the COVID spike protein, and then the messenger RNA is gone. So it's not sticking around. Based upon that messenger RNA not being present in your body for long periods of time, I can't wrap my head around how we could see long-term side effects. So even though we don't have 5-year safety data, I felt comfortable for myself, for my family, for individuals I work with, getting the vaccine based upon what messenger RNA really is and what it does. Are we going to see short-term side effects in some people? Absolutely. And so no vaccine in the history of humanity is free of all side effects. Vaccines are designed to generate an immune response. And so when you generate that immune response, it is possible that you could have too much of an immune response. So the common side effects that we would expect to see with vaccinations are things like soreness at the injection site, maybe a little low-grade fever, not feeling great, fatigued, headache, a little achy. And typically those things are going to last for 24 hours. With the Pfizer and the Moderna vaccines, the 2-part vaccines, you're more likely to have those side effects with dose number 2 than you are with dose number 1. We are going to see occasional side effects that are more than that. Things like Guillain-Barré syndrome, Bell's palsy. These are all autoimmune reactions where your body has made a little bit too much of an immune response to that vaccination. The likelihood of having one of those immune reactions to the vaccination is actually much less than your likelihood of having that immune reaction to the virus itself. We've seen this with other vaccinations, for instance, measles. There are things like low platelets that you can see with a measles vaccine, and people get concerned about that side effect with the vaccination, when in fact your likelihood of having thrombocytopenia or low platelets is much higher with the actual infection than it is with the vaccination. What we've told individuals with MS that we work with, and what we've told our staff here at Shepherd Center, is that I'm not trying to twist anyone's arm into getting vaccinated. I feel like our job is to be a guidance counselor. Whether you're a healthcare provider thinking about getting vaccinated or you're a person with MS thinking about getting vaccinated, I want you to have all the good information, not just social media information, and for you to make an informed decision based upon that information. If you decide at the end of the day that the vaccine is not for you, as long as you've made that decision with all the information in front of you, I think we're okay with that. Me personally, as a healthcare provider, I felt like in my occupation there was somewhat of an ethical obligation to get vaccinated, because the last thing I wanted to do was to have an asymptomatic case of COVID in myself and give it to someone in the exam room. Even though we're masking up and doing everything that we can do to prevent transmission, I felt like that would be a sort of a dereliction of my duty as a healthcare provider to give it to someone else in the exam room. Where there's been a lot of discussion is over different disease modifying therapies in multiple sclerosis and vaccinations. When we think about what our disease modifying therapies do in MS, they all work in our immune system and they all do something to our immune system. Could that mechanism of action potentially change the effectiveness of the vaccine? Certain of our therapies, we think that's very, very unlikely. So some of our old injectable medications, for instance, glatiramer or Copaxone, any of our interferon therapies, very, very unlikely that any of those medications are going to have any effect on how the vaccine works. Probably the ones where there's been the most concern would be over our B cell therapies. So this is going to be Ocrevus, Rituxan, Kesimpta, these sort of drugs. So what the National MS Society has advised is that if you're on Ocrevus or Rituxan, these are every 6-month IVs, is that maybe you think about getting vaccinated at the 3-month mark. So in between your infusions, not for safety reasons, but to maximize the benefit that you're going to get from the vaccine. In reality, and I don't disagree with that necessarily, but I think we also need to be honest and say we really don't have any data to make that recommendation one way or the other. That recommendation is based upon when your body starts making B cells again and when you're most likely to make a good antibody response to the vaccine. So what we see in our clinic, we're very proactive in safety monitoring with any of our drugs, but with the B cell therapies, we follow people's immune system. And what we're seeing is that the B cells that are affected by these drugs like Ocrevus and Rituxan and Kesimpta, people are on a pretty even keel. So their B cell subsets really don't change the day before their infusion, a week after their infusion, 3 months after their infusion. So in my mind, I'm not sure how absolutely crucial it is that we do that 3-month. And so we've been kind of a little more liberal with our recommendations. What I don't want is for someone who is interested in getting vaccinated to miss a window of getting vaccinated while they're waiting for that 3-month mark. So we know that the B cell therapies that they're designed to lower a certain subset of B cells. Well, some B cells grow up to become a plasma cell. And what plasma cells do in our body is they make antibodies. And so there was a concern that maybe these B cell therapies are going to decrease the antibody response that you would get to COVID vaccination. And it's an unpublished study, but there was data presented at the Academy of Neurology in May of this year that looked at people on B cell therapies who had actually had COVID infection. And we think this would probably apply to vaccination as well. And what they found is that people on B cell therapies, about 50% of the time, did not make an antibody response to COVID infection. But when you looked at their T cell response, all of these individuals made a good T cell response. So those are the two major components of our immune system, B cells and T cells. And we had always suspected that these B cell therapies like Ocrevus really should not affect the T cell part of our immune system. And what this study that was presented at the Academy of Neurology showed is exactly that the T cell response was intact. That made us feel good that people on these B cell therapies should be still making some type of immune response, either to the natural infection or to the vaccination itself. The problem with the T cell immunity test is it just recently got FDA approval. And to my knowledge, there's still only one company in the United States, one lab that has the patent on this and is running this. And so it's not quite as easy to get as the antibody test, the B cell test. So should people on drugs like Ocrevus if they get a COVID infection or get vaccinated, should they be getting COVID antibody testing done to see what's going on after infection or after vaccination? The CDC would say no. And so the reason is that we're not really sure that the antibodies we're measuring with COVID antibody testing are the antibodies that actually convey immunity. And if you put on top of that, that it looks like about 50% of patients, at least on Ocrevus and Rituxan, are not making antibodies, but they still make T cells. The question is, what are we really measuring? Are we giving people useful information? So we are not recommending COVID antibody testing to look for immunity. And again, those are per CDC guidelines. The other thing that to me is reassuring, and this data came out of the University of Washington just about a week ago. So all of us are interested in the long-term immunity. So if I've been vaccinated or if I've had the actual infection, how long am I immune for? And some of the early sort of conventional wisdom was saying, well, if your antibodies go away, then you're no longer immune. And several groups, including researchers at the University of Washington, are saying, not so fast. What these researchers did is looked in the bone marrow for memory immune cells. And what they found was evidence of memory immune cells in the bone marrow of people who had been infected or had vaccination. And these types of memory cells that they saw should last for years. And so even though these individuals had lost their antibody response after vaccination or infection, they still had these memory immune cells, which would suggest that again, they're going to have long-lasting immunity. That's going to be important as we start thinking about things like booster doses. You know, if you've been vaccinated, do you need to get a booster dose once a year, once every 8 months, once every 2 years? We don't have the final answer on that, but this newer research that's coming out, which I find reassuring, would suggest maybe we're not going to be doing booster doses on a once a year. I think the challenge is going to be, you know, how do we know that in an individual? You know, if there was a blood test that could look for these memory immune cells, that would be wonderful, so to show that maybe that person doesn't need a booster dose. If we can only get that information through doing bone marrow biopsies, I don't think people are going to want to sign up for that. And so if you said, well, you can do a booster dose once a year, or we can do a bone marrow biopsy and see if you need the booster dose, I'd probably just take the booster dose, because it's going to be a lot easier path at that point. So there's a lot that you know we've learned over the past year and a half. There's still quite a bit that we need to know. Some of the the ongoing issues that we're struggling with too are things like the variants that are coming out. Right now in the United States, about 1 in 5 cases of COVID are the Delta variant. The good news is that we do have data for Pfizer and Moderna showing that they do seem to be effective with the Delta variant, at least in terms of preventing severe infections, keeping people out of the hospital. There's not data quite yet on the Johnson & Johnson vaccination. We're keeping a watch on a variant that we're seeing come out of India right now, the Delta Plus variant. We don't know what that means. Fortunately, there are not a lot of cases of this. I know as of last week, there were only about 200 cases that have been identified globally of this Delta Plus variant. And so we'll need to watch and see what that means in the long run. There have been some potential silver linings in the whole COVID experience. I don't know if folks may have seen about 2 months ago, so the researchers with Biontech is the Pfizer partner that helped develop their vaccine, looked at the messenger RNA technology and are realizing that we may be able to use this messenger RNA technology for things other than just traditional antiviral vaccines. And one of the things that the researchers were interested in looking at was potentially developing an MS therapy. And the concept is called immune tolerance. So immune tolerance would be getting your immune system to stop picking on the brain and spinal cord and start tolerating myelin proteins rather than attacking them. very similar to the idea behind an allergy shot. So if your immune system reacts to, say, ragweed, what if we could give you exposure to small doses of ragweed through subcutaneous injections and teach your immune system to tolerate it? So what the researchers at Biontech did is had the messenger RNA code for myelin basic protein. So now your body is going to produce these small amounts of myelin basic protein, and hopefully your immune system will learn to tolerate it rather than attack it. What we know so far is it worked in the animal model, the mouse model, experimental allergic encephalomyelitis. It is in human testing right now. Realistically, you're probably looking at at least a 4-year path until we get the final verdict. But that would be wonderful, because that would be, you are essentially then potentially vaccinating yourself against multiple sclerosis. So this would not be a repair strategy. It would be sort of a replacement potentially for disease modifying therapies, but the convenience would be, in theory, amazing. So you could go into your neurologist once a year, do your intramuscular vaccination, and then you're good to go for a year at that point. So maybe down the line we get something really good and cool as a silver lining to the whole COVID experience. As we come out of the COVID pandemic, I think one of the messages we want to get out also is that if you've put any of your routine health maintenance on the back burner, but think about getting these things up to date. If you've not seen your primary care doctor, if you've not had routine health screenings, mammograms, pap smears, prostate specific antigen, all of these things that we should get, touch bases with your primary care doctor. A lot of people who are listening in, you put a lot of time and effort into taking care of yourself as it relates to multiple sclerosis. Don't neglect the other parts of your healthcare. Make sure that you're getting all of those things. If you've not seen your dentist in a while, get those things taken care of, because I think a lot of people did put some of these things on hold. There's been a trend for some cancer screenings to really fall by the wayside during the COVID pandemic. And I think now is the time to think about re-engaging with those practices. And with that, I'm going to throw it open to the audience and see what questions or thoughts we have out there.
All right. So to everybody that has a question, you can either type your question into the Q&A chat features or use the raise hand feature at the bottom of your screen in the toolbar. We do have some questions in the Q&A. First question is from Sherry, and her question actually coincides with one that someone named Caroline emailed to us. And again, I know you talked a little bit about B-cell depleting therapies, but perhaps you can just reiterate. Caroline asks, what is your advice for fully vaccinated patients that are on B-cell therapies like Ocrevus or Rituxan, for whom the vaccine is proven not as effective and most of whom are at high risk of serious COVID-19 complications?
Yeah, it's a tough question. And so I'm not sure that we can say definitively that the vaccines are ineffective in people on B-cell therapies. I think if we look for antibody responses in people on B-cell therapies, clearly 50% of people are not making a B-cell or an antibody response. But I don't know that means that you are completely unprotected. Again, so what we saw in the study from Academy of Neurology is that it looks like everyone on B-cell therapies is still making a T-cell response. Does that give you complete protection or as much protection as someone who's not on B-cell therapy? We don't know that. We do know that the European experience was that people on B-cell therapies did have a higher risk of hospitalization if they got COVID. And part of that could, and this is theoretical on my part of that could have to do with laboratory monitoring. So when you think about someone on a B-cell therapy for multiple sclerosis, you want that B-cell therapy to work on only those B cells. Sometimes those B-cell therapies do more than that. sometimes you can affect the T cells. So Ocrevus and Rituxan and Kesimpta are what we call anti-CD20 monoclonal antibodies. CD20 receptors are present on B cells when they're immature, and then they tend to disappear from that B cell when it starts becoming mature and becoming an antibody producing plasma cell. Those CD20 receptors are also present in a small population of T cells. And so one of the reasons it's important to measure T cell subsets in patients on a B cell therapy is that those B cell therapies, at least that CD20 B cell therapies, are not really completely specific to the B cells. They do have the potential to lower T cells. And so what we've seen and what we've seen in some of the studies with these B cell therapies is that somewhere between 5 and 6% of the time, patients on Kesimpta, Ocrevus, Rituxan will have their T cell subsets lower. And so that's CD4 and CD8. So you do want to measure those in patients on B cell therapies. The other thing that can happen with these B cell therapies is sometimes you will lower IgG and IgM levels. So between those two antibodies, IgG appears to be the one that's most associated with a higher risk of infections. So you want to check those as well in patients on these B cell therapies. So when we see a patient on a B cell therapy, we tell them we really want to see three things. We want their total lymphocyte count to be normal. We want the B cell subset to be low. That's what the drug's designed to do. We want their antibodies and their T cell subsets to be normal. So if someone has low T cell subsets on one of these B cell therapies, or their IgG levels are low, we need to do something proactively. We don't want to wait until they have some sort of infection. So we'd like to alter their dose somehow. Typically with a drug like Rituxan or Ocrevus, it just means keeping the 6-month regimen, but just lowering the dose. So that's a long roundabout way of answer of saying, so we need to be doing some work on our end at the medical side to make sure people are not at risk for infections. Because even if we're doing all of those things appropriately from the medical side, we still don't know for sure if people on Ocrevus and Rituxan and Kesimpta are getting a full vaccine response. I think it's reasonable for people with MS on those drugs to maybe exercise a little bit more caution. Maybe you want to be, careful in public gatherings. Maybe you want to be a little more mindful about, masking or being around, people that are potentially sick.
And I'll address Sherry's next question. She says, do you have any suggestions about how to get our vaccine-resistant family and friends to get vaccinated?
Yeah. Well, that's a good question. So what we did here, at Shepherd Center, for instance, with our staff, is we really spent a lot of time trying to give general information and then trying to meet with individuals or groups and individuals one-on-one. And so my experience with people who are concerned about the vaccine or don't want to take it, there are a lot of different reasons people have those concerns. And I think you really need to dig in and say, what's your specific concern? And then give them information to address that. Realizing we do have some gaps in our knowledge. If someone says, I will not take a vaccine until there's 5 years of safety data, I don't care what you say. That's a tough one because we don't have that information. I think we looked at our staff here, for instance, the Black population, the Latino population, young women, they all had specific concerns that they, wanted to see addressed. And so we tried to meet with groups individually to address that. My fear is we may have groups of people who just for whatever reason are just not going to do it. And that's sad and frustrating. And I'm hoping we still get some stragglers coming in, maybe that groups of people who wanted to see more numbers of individuals vaccinated to make them feel good about it. I wish I had a magic one-size-fits-all answer for that, but everyone comes at this from a different angle. Sadly, this whole situation has been so politicized also on both sides of the ledger that you're dealing with that as well. And sort of, yeah, and I really encourage people to, when you're having that discussion with someone who's vaccine resistant, take the politics out of it. This is a virus. It's not Democrat. It's not Republican. It's not Libertarian. It doesn't care what your politics are. It's biology. And so just look at the science of it, and put all the political noise aside and make your decision what's right for you and your family's health.
And Caroline has a kind of a three-part question. She says, are we free to live our lives normally and mask-free per the CDC guidelines, or should we continue masking indoors in public and/or in crowded settings until further notice? What should our subgroup expect our lives to look like now in terms of re-entering society on a short and long-term basis?
Yeah, I think that's a great question. So my feeling is that if your medical team is doing all of those immune markers, so you've got normal T cell subsets, normal lymphocyte counts, normal IgG levels, I think your risk of getting COVID or having a bad outcome with COVID is low. It's not zero. There are still things we don't have the absolute answer to. So, in my experience, our patient population, 3,000 individuals, the B cell treated patients have not behaved significantly differently than any of our other patients. They've not really behaved differently than our staff in terms of COVID risk. So this is where Caroline's going to have to, and other people making this decision, we all have our own internal risk tolerance. And because we don't have an absolute answer, for that, I think those people are going to have to make sort of a risk assessment for themselves. Because we cannot give an absolute safety guarantee, maybe wearing a mask is right for that individual. I mean, no one's been hurt by wearing a mask out there. And so if they feel more comfortable and they want to increase their safety just a little bit, there's certainly no harm in continuing to wear a mask when you're out and about. There's no shame in doing that. Again, it's cheap, it's easy, and no one's ever been hurt by it. On the other hand, if someone said, does that B cell treated patient absolutely have to wear a mask? If all of those other immune parameters are normal, I think it's okay to not in settings where you're outdoors, where the risk is low. That there are intangibles in all of this also. We've had people who've not seen family members, they've not had vacations, and I think mental health has suffered quite a bit through this whole situation. So I think there are a lot of different variables that we have to think about and into coming up with what's the right answer for that given individual. You probably need to know what your local environment is like. Are you in an area where maybe some of these variants are starting to creep back up a little bit? You maybe, for instance, I know Los Angeles just recommended that people go back to masking in indoor settings where there are larger crowds because they're starting to see some of the variants creep up a little bit. So a lot of moving parts to that question.
We have so many questions flooding in, and we're going to get to all of you. We see some hand raises, some questions in chat and in Q&A, so just bear with us. Our next question comes from Tina. She asks if you could explain messenger RNA, what it is and how it works.
So again, messenger RNA, so you have RNA and DNA. And so DNA in mammals, that lives in our cell nucleus. And so one of the concerns people have had about these vaccines is, are these vaccines messing with my genes? Are they going to permanently alter, my genetic makeup? Absolutely not. Messenger RNA never comes close to your cell nucleus, your DNA. So again, think of messenger RNA as like a blueprint. So if you wanted to tell your body, hey, build this for me, build this protein, the messenger RNA is the blueprint for that protein. So your body is going to see that messenger RNA and say, oh, look, that's a roadmap for albumin or some other protein. In this case, it's the blueprint for the COVID spike protein. So they specifically took messenger RNA that's going to tell your body to make that little piece of COVID spike protein. Your immune system is going to see that COVID spike protein and say, oh, I must have COVID. I'm infected. You're not. You just have that little bit of that protein floating around. So you're fooling your immune system into thinking you have the infection. You're making an immune response to that COVID spike protein. Now your immune system has the memory to attack that COVID spike protein when it sees it. So the idea is if you get exposed to the real deal virus in the future, your immune system says, oh, I got this. I've seen this spike protein. I'm going to make an immune response to it and wipe it out.
I'm actually going to allow Karen to talk, so you can lower your hand and speak directly to Dr. Thrower when you're ready.
Myself. Thank you, Dr. Thrower. I just can't tell you how grateful I am. Just a few minutes of your speech taught me so much, that questions that I think about at 2 in the morning. So thank you for that.
Oh, you're very welcome.
I'm on Kesimpta, and I went off of it for 11 weeks between the last time I dosed myself and the time I resumed. And in the interim, I had gotten the Pfizer vaccine. I always am confused. I understand you have to be in that washout period in order for your body to build the immune response from the vaccination. But what happens after that? If I were to assume that I created the right immune response, is the resuming the medication, would that deteriorate that immune response?
Yeah, great
in the
question.
future?
No, it should not. So you've made memory cells. So you now have those cells living in your bone marrow. Even though, so if we did COVID antibody testing, you may or may not have COVID antibodies, but you have those cells in your bone marrow that are waiting for, God forbid you were exposed to the COVID virus, but if you were, those memory cells are sitting there in your bone marrow. The Kesimpta doesn't wipe those out. So Kesimpta and Ocrevus and Rituxan work on immature B cells, not mature B cells. So they're affecting just those immature ones that are going to, again, give you MS protection. So resuming your Kesimpta should not have any effect on the immune response you got from the vaccine.
Whatever that is. And a part two, if you don't mind, I've always thought if it's getting rid of the teenagers or the immature ones, isn't that interrupting the whole generation of those cell line?
So only the B cell lineage. And so you have different populations of these teenagers. So you have cells that are living in tissue, cells are living in the bloodstream. So you're right, though, we probably are affecting the ability to make a new population of antibody producing B cells. That's the way the drug works. So Kesimpta is the shortest acting of all of our B cell therapies. So when you stop the drug, your bone marrow will start making those B cells again. So you do probably affect the ability to make a certain population of mature B cells. But again, remember, you've got the T cell part of your immune system, and if the Kesimpta is doing what it should be doing, only affecting that B cell lineage, you should not be affecting the T cell population. We know a lot of what kills virus is a population of T cells called CD8 cells. Well, we can measure those. When you go in for blood testing, what we do here is we send off something called quantitative lymphocytes. So it's a test that looks at breaking down your lymphocytes into populations of B and T cells, and so we can tell exactly what someone's CD8 population is.
Okay.
So I do think that our B cell therapies do potentially affect the ability to make a certain population of B cells, but they shouldn't affect the T cell population.
Okay, understood. Thank you so much.
Yeah, absolutely.
And we have a question in the chat from Andrea. She said, should vaccinated people on Ocrevus still be masking inside?
Yeah, again, that goes back to that risk tolerance question. There's no, I can't tell you absolutely yes or no. I would say that I do think the antibody response is affected to vaccination with Ocrevus. So it is possible that people on B cell therapies are not getting the full benefit that, say, someone without a B cell therapy. Again, they're still getting something. Is it 50% of a non B cell treated patient? Is it 75%? We just don't know. And so if I said that your vaccination response is a little bit less, or maybe half, at what point is that not okay with you? And you say, okay, I want to put a little more protection for myself individually. I'm going to wear that mask indoors. That's what it really boils down to. And I think there's no right or wrong answer to that. It's what risk you're willing to accept in that equation. The analogy I always use is, if my wife and I have been big Harley Davidson people, and I have friends who would say, why in the world would you ever ride a motorcycle? That's such a dangerous thing to do. So for me, that risk was acceptable. For someone else, it might not be acceptable. And so I think this is a very similar analogy. I would always come back to the fact that, masking is a hassle, but it's a pretty safe hassle, and no one's ever been hurt by it. So if you have concerns at all, it's not that big of a deal to go ahead if you're in any kind of setting where there's a lot of people and mask up. I think too, if you were with family, and let's say you're at a family reunion, every one of your family members is healthy and they've all been vaccinated, well, you've got your own little herd immunity going there. So even though you might be in a setting where there's more people, maybe you feel more comfortable not masking in that setting because these people and they're vaccinated. If you're in a restaurant and now you don't know most of these people and you don't know if they've been vaccinated or not, maybe that's the setting where you want to exercise a little more caution and mask up in that setting.
So in our emails, we got a question from Anne. She said, I'd like to ask if there has been any relationship found between receiving the COVID vaccine and developing MS symptoms. One of my family members received a vaccine in January and within a week developed seizures, eventually realized to be related to MS, which was only diagnosed after the seizures and later partial TM developed. One neurologist said the inflammatory reaction to the vaccine caused the seizures, while another neurologist disagreed.
Yeah, so again, vaccines do generate an immune response, and every vaccine out there, I can show you a small number of people who've developed transverse myelitis. There's another condition called ADEM, acute disseminated encephalomyelitis. Acute disseminated encephalomyelitis on MRI it's a demyelinated condition. It looks like angry multiple sclerosis. ADEM is associated with seizures. We had an inpatient here at Shepherd, two actually, one after vaccination, one after natural infection, who developed ADEM. So these are autoimmune reactions, and they can happen after natural infection and after vaccination. So I think that, given what she's asking, I think it is very possible that was a post-vaccination reaction that happened.
And Tina has another question from the Q&A. She says that she had a major reaction to the Pfizer vaccine, had 104 fever, numbness, weakness, etc. What will happen with a booster? I think she's saying her son was vaccinated as well. And what's the likelihood of him having a severe reaction when he can have the vaccine?
Yeah, so we are seeing individuals, have a little bit more than the usual, reaction with typically it's going to be with dose number 2. People with MS generally know if they get a low-grade fever, they get a viral infection, their old symptoms are going to act up. They're going to have numbness, tingling, weakness, fatigue, visual loss. So these are called pseudo exacerbations. And I think if you have a big enough reaction to the vaccine, you could have a transient increase in old neurological symptoms. It should not be a true relapse. So those symptoms should resolve once your temperature is back down into a normal range. So it's a little controversial as to whether people should pre-medicate with vaccination, you do some Tylenol, ibuprofen, Aleve. In the pediatric world, they advise against it because they do feel like there's the potential to get less of an immune response to the vaccination. I would say if I'm an individual who had 104-degree temperature elevation after vaccination, I'm probably pre-medicating next time if I do have to receive a booster. The person's immune system, with the booster, is the pump has been primed. The reason we see more side effects with dose number 2 than dose number 1 with Pfizer and Moderna is your immune system's seen that vaccine, and now it's going to make a bigger immune response the second time. We want that on one hand. On the other hand, we don't want too much of it so the person's having side effects. I think it is possible that with booster doses in that sort of setting where people have had a 104-degree temperature elevation, you could have a little bit more of that type of reaction. And I would probably think about pre-medicating in that setting. I think it's going to be really helpful if we can get more science out there telling us, do we really need to get boosters over time? I think if the science froze where it's at right now, I think the consensus would probably be, yeah, we're going to be doing boosters on a once-a-year basis. I'm hoping that as the time comes that we need to start thinking about that we have more data to say yes or no, or is it in select individuals, maybe individuals on B-cell therapies, for instance, if we're thinking maybe you didn't get the full bang for the buck with your initial vaccination, maybe there are certain populations that should really give some strong thought to doing boosters over time.
And David, you can unmute yourself and speak with Dr. Thrower.
Good afternoon, Dr. Thrower. Great presentation.
Thank you.
My question, no problem. I am from the Bahamas, and we do not have Pfizer, Moderna, or Johnson & Johnson. We have AstraZeneca. I have MS, and my question to you, do you know about the whole AstraZeneca and the whole MS?
So what's different with the AstraZeneca is they added a little extra step in there. So the AstraZeneca is a DNA vaccine. So it's the DNA is sort of produces in our cells the messenger RNA. So it ends up being a messenger RNA vaccine. There's just an added step in there. Talking to our colleagues in the UK where AstraZeneca has been the vaccine, we're not hearing anything from our UK, their version of the National MS Society. They're not seeing any issues in the MS community. I mean, if all things were equal, and if you had all of the vaccines, I would still probably prefer Pfizer or Moderna just because you cut out that one extra step. If that's not feasible, again, I feel pretty good with the safety with AstraZeneca from an MS standpoint. Again, we're not hearing of any problems through our partners in the UK.
Mm-hmm. Okay. All right. Thank you.
Yeah, absolutely.
So sorry. Robin from Facebook asks, she said that she got the Pfizer vaccine and she's on Tysabri and wondered if it was safe to be around people. I know I won't get the vaccine because they've tested positive for the virus and have had minor symptoms back in December.
So we've not seen any issues with Tysabri affecting vaccine effectiveness. So I think a person on Tysabri really gets the full benefit from Pfizer or Moderna. Just as a curious anecdote, early on, before we really thought about the COVID antibodies, just for fun, we did some COVID antibody testing in Tysabri patients, and they generate a big antibody response. So they're probably as much or more so than any other of our MS therapies. I can't explain why that would be. Why would a Tysabri patient get more of an antibody response? So I think people on Tysabri are getting the full benefit of the vaccine. So I think she can almost make her decision independently from her disease modifying therapy.
We have a question in Q&A from Jennifer. She says, what do you suggest people on B-cell depleters do in terms of being able to get back to life as normal? Will we be switching people of B-cell depleters to a different DMT?
So that last part of the question, I don't think so. So, there are two schools of thought on how we manage MS. There's a camp called escalation therapy and another group that's called induction therapy. Escalation therapy means I pick a therapy, maybe like an old injectable therapy, and then if you're not doing well, I'm going to move you up to something more effective. Induction therapy says I'm going to pick something really effective from day one. Really effective therapies are things like Tysabri and Ocrevus and Kesimpta and those drugs. Because those drugs are so effective, I think if the medical community is doing our part in monitoring those other immune functions with lab testing, I think it's okay for people to stay on B cell therapies. We have not taken a single person off of a B cell therapy, with the only exception being maybe individuals over the age of 65 with primary progressive MS, just because in some of those older individuals early in the COVID pandemic, we knew that that group was at higher risk for having a bad outcome if they got COVID. It wasn't always abundantly clear that their therapy was really doing a lot for their primary progressive MS. So in some of those individuals, we did make a decision to hold or even discontinue their B cell therapy. For patients with relapsing remitting MS, we have not taken a single person off of B cell therapy during the COVID pandemic.
All right. So Betsy, you can unmute yourself and talk to Dr. Thrower whenever you're ready.
Hi, I'm just wondering now that we've seen, the Moderna and the Pfizer's out, what is your opinion on a 19 and 15-year-old getting these vaccinations?
Yeah, so my wife's a pediatrician, and we have these discussions a lot at home. Because above the age of 13, it looked like teenagers seem to have about the same risk of getting COVID and maybe transmitting COVID. Now, granted, teenagers certainly are going to do better in terms of how their COVID acts than say a 70-year-old. I still, if my kids are older than that now, I would probably vaccinate 13 and up. Where I'm still struggling, and I probably would really need to think about it, would be under the age of 12. If you look at the grade school age kids, they don't seem to be getting COVID very often. If they get it, they're largely asymptomatic, and they don't seem to be transmitting it. The CDC did a study here in Metro Atlanta, Cobb County. They looked at COVID transmission in schools, and when they looked at grade schools, they could not identify a single case of a child under 12 giving COVID to one of their teachers. There were cases of teachers giving it to each other, and teachers maybe transmitting it to children. But I think from a public health standpoint, I just don't think that the under 12 group is our high risk group. Now, if we get a weird variant, that maybe that changes. But yeah, I would probably vaccinate above 13, but I'd have to really see more data for under 13. That's just my personal opinion.
Great, thank you.
Yeah.
And we have a question from Sue. She asks, for people fully vaccinated, do you think it's safe to go back to church or the gym, potluck dinners, etc.?
Yeah, I mean, the vaccines, the effectiveness is good. So with Pfizer and Moderna, even with one dose, you're up in the 90% range for protection. You add that second dose and it's up to about 95%. So you are going to read, things in the press and the media about people who've been vaccinated getting COVID. It's going to happen. So if we say that after 2 shots, you're 95% protected, well, that means that 5% are, could still get COVID. So when you look at the millions of people who've been vaccinated, if you do the math on that 5%, that there will still be people who are vaccinated who can get COVID. So I think, again, it comes down to that risk tolerance. What is the risk of infection in a fully vaccinated person versus what's the benefit that you get out of doing these things? Again, I think people have suffered during this pandemic. I mean, we've seen more depression, more, domestic abuse, more alcoholism, more drug use. And so I think people would like to get back to their support systems in church, in restaurants and things. For a lot of people are a part of that. I know a lot of churches are trying to, walk the line between getting back to in person, but also offering some protection. I know, for instance, our church is not doing the choir. If you think about choir, unmasked, you're kind of really projecting a lot of, air out into your church environment. So I think there are compromises that we can make where maybe we go back to church in person, maybe choirs, you want to think about it. It's hard to sing with the mask on. So
Yeah.
I suspect, real shared communion and, Catholic and Episcopal Lutheran churches is probably not coming back anytime soon where we share the chalice. I don't see that as being, but yeah.
Yeah, probably not. And a lot of churches are doing virtual sermons, so thank goodness we have that at our fingertips too, because I have not set foot in a church really since the pandemic started either. I've been watching online most of the
I
time.
know, like our church, you have to make reservations actually, so they cap it at a certain amount, and so so they're really keeping the spacing up. They have certain pews, blocked off, and so when you go in, it's pretty well spaced out.
And question from Claudia. She says, is Mayzent considered a B-cell therapy? How do I know how effective the vaccines are? When will the T-cell tests be widely available?
Yes, so Mayzent is in the class of drugs called S1P receptor modulators, sphingosine 1-phosphate receptor modulators. So it's not a B-cell therapy. So this would be your Gilenya, Mayzent, Zeposia, those types of medication. So these are drugs that don't really kill any cells. What they do is they lock up certain lymphocytes in the lymph nodes. They don't let them get out and circulate and cause inflammation. So that's how they work in MS. Lab testing is always a little interesting in patients on drugs like Mayzent, because if we look at the lymphocyte count in someone on Mayzent, it's going to be very low. If we do T cell subsets in patients on Mayzent or Gilenya or Zeposia, they're going to be very low, but it's a false depression. We can only measure things on a blood test that are in your bloodstream. If these drugs like Mayzent are locking up some of those lymphocytes in your lymph nodes, well, they're not dead, they're just not circulating in your bloodstream. So we get kind of the false impression that your cell counts are really low when really they're not. The cells are there, we just can't measure them. So there has been some evidence that the S1P drugs like Mayzent can potentially lower antibody production after vaccination as well. But again, and I've not seen this data, I would expect that the T cell response is still there in a patient on Mayzent. In the real world, we've not seen patients on the S1P drugs like Mayzent behaving any differently if they do get COVID. And I think ultimately that's what you're really concerned about is, if I get COVID, or am I going to get sicker, or am I at higher risk for getting COVID because I'm on a drug like Mayzent? We've not seen that in the real world, so I think that's reassuring.
And Karen wants to know if you've seen people taking Ocrevus have a decline in their walking since starting it. She says there's lots of buzz about walking getting worse. I believe from this, she says she's on Ocrevus and her neurologist still doesn't think, well, it's safe to go to the gym and take masks off. So I guess the question is more so about Ocrevus.
Yeah. So, unfortunately, as good as some of our drugs are, like Ocrevus and Tysabri, nothing's perfect, and so there will always be people who are going to still progress even when they're on a really effective drug. And so I can't think of a mechanistic reason why Ocrevus would actually make people get worse. But I think we have to be honest and say it is possible that people do get worse, not because of the Ocrevus, but in spite of the Ocrevus. So they're just, and one of the concepts we're really starting to wrap our head around is this concept of loss of neural reserve. So I will guarantee there are people on the line right now that will go in there, no matter what therapy they're on, they're told that their MRI is stable, no new lesions. They're told they're not having any relapses, but they're still getting worse. And so how does that happen? If my MRI is not changing and I'm not having attacks, why am I getting worse? And we think that what may be part of that is that even though the MS lesions are not changing, after age 30, all of us start losing some reserve status. All of our brains start shrinking a little bit after age 30. It's normal human biology. So the person who has a lot of old MS lesions that maybe aren't giving them any issues, their brain has sort of has taken the hit and they're not getting any symptoms. As we lose reserve status, maybe those old lesions start becoming a problem. So the lesion itself hasn't changed any. Our reserve status is lowered. So think of like a lake level. So you've got this old MS lesion that's below the surface of the lake, and now with loss of neural reserve, normal human aging, now it's above the surface of the lake. So that may be what we're seeing that causes progression of symptoms like walking issues, even when the person's on a really effective therapy and their MRIs aren't changing. It's a great explanation. It does raise the question, okay, what do we do about that? So we're a big believer in wellness and rehabilitation, trying to get people as strong and fit as they can be. We know that reconditioning people, putting them into exercise programs does improve function, but ultimately we need repair strategies. We need a way of either making that old MS lesion smaller, so now it's back below the surface, or putting more water in the lake so that we reverse disability. And we are getting closer to that idea. I do believe it's going to happen. I wish it was happening faster.
Dr. Thoreau, how much time do you have? Because we are at the hour mark already, and we still have some questions in the chat.
Let's do another 10 minutes.
Okay, sure. So Tina, I'm going to let you just speak directly to Dr. Thoreau because I see you have several other questions in the Q&A. So please feel free.
Yeah, sorry about that. I didn't mean to have so many questions, but the doctor has a lot of great information, and I think this is definitely something that all of us with or without MS are concerned about. So I am on Ocrevus, and I'm relatively new to it and new to MS. I've been diagnosed since 2019. The question, I have a couple questions. One, should I be asking my doctor to do a T cell count, the IgG and IgM levels and the lymphocyte levels, since I was the one that had the severe reaction with the high fever and everything? I did not pre-medicate. I didn't even post-medicate. I suffered through it. It was horrible, but I couldn't feel my hands or my feet or anything. But it went away about 12 hours afterwards, and I just was, crazy. But I'm curious if I should be asking for that test to see if the vaccine messed with any of those things.
So so putting the vaccine aside, and I think everyone on a B-cell therapy needs to have regular lab testing. And I think that lab testing needs to include a CBC, liver function studies, the quantitative lymphocyte count, and an IgG level. Again,
and I know they do that prior to the infusion.
Yeah.
I know I get a bunch of those.
So that's the way we do it also. So what we do is we get those before we ever start therapy, and then we get them with each infusion. And then in the first year, we like to see people back at the 3-month mark in between infusions, and we get those labs then. And that's just us. So I like to have a year's worth of quarterly data, so I really know that your immune system is on the same even keel all throughout your 6-month regimen. After the first year, we drop those in between lab tests, and we only do the labs with your infusion. So that's fine to do them on the day of the infusion.
Okay, that's good to know. So I'm going to double check and make sure that I'm up to date on that. The other question I have is, I'm an older mom of a younger child. I have an 8-year-old, so obviously he is not eligible for vaccinations right now. And and I live in California, I should let you know that as well. I'm hoping, Bay Area, not Los Angeles. I'm hoping that, they'll be able to go back to school. He did distance learning this whole time, which is fine since I'm a former teacher. However, I do hope he can go back. But here's my question. I don't know if they're going to require masking and stuff like that and the social distancing that they did, because they did have some of the kids go back and they did do the distancing and things like that, required them to wear masks. Do I need to be more concerned since I am a B cell therapist? Because I know you were saying should be a little, I wear masks indoor all the time. We even wear them outdoor. My son does. It's all good. But, you get back to school, you forget, they may not enforce it. Should I be concerned about that more? And then the other question kind of on top of that is, you were talking about the younger children with vaccines. I know a little bit about biology, or at least I think I do. With the hosts, such as us as adults and now teenagers being not removed per se, but getting protection against this vaccine, won't the virus start looking for other places to fester? And that's why variants are becoming big. And that's the other thing I'm concerned about is variants. So it's kind of a 3-part, 2 parts with kids and 1 about how worried should I be as a B cell person with variants.
Yeah, so I think you're right on the biology. So viruses mutate. I mean, that's what they do evolutionarily. And sometimes they mutate in ways that it makes them more reproductive, but it makes them less virulent. So they're you think about JC virus, the one we're so concerned about with some certain MS therapies. I mean, it's an everywhere virus. Every adult probably in the world carries JC virus, but it became totally benign as long as your immune system is intact in terms of causing human illness. It's evolved to the point where it just uses us as transportation for the most part. I think with an 8-year-old, again, even though I think those kids could be potentially carrying the virus. COVID uses the ACE receptors to get into our cells. That's what the spike protein is binding to. Kids just don't have a high concentration of ACE receptors on their cells, so they don't have huge viral loads. That's why we think, number 1, they're not getting as sick, and number 2, they don't seem to be the transmitters. So I agree. 8-year-olds, 8-year-olds may or may not mask. They're going to take their masks off to eat and sneeze and make faces at each other. So I don't know that we can count on them, always being the greatest at masking. But I do think that they are unlikely to transmit. So, I wouldn't worry that much about an 8-year-old going back to school in terms of them bringing it home to you and being a reservoir for transmission. Again, the vaccinated 8-year-olds or not, I'd like to just see a little bit more data on that. And I think because right now they seem to be at lower risk for getting sick and lower risk for transmitting. I'm just not sold yet on vaccinating the under 12 group. I think teenagers, whole different animal. They're behaving more like adults. So yeah, I would do them. So yeah, I think your risk. It sounds like you're getting appropriate laboratory monitoring done. I think your risk of as your 8-year-old goes back to school shouldn't be significantly high.
And it looks like she muted herself again. So Lisa, please take it away.
Sorry, I didn't mean to. I thank you very much, Doctor. I appreciate that. And I appreciate you giving me the time.
Absolutely. Thank you.
Lisa, are you there?
Yes. Can you hear me? Okay.
Yes.
I had COVID at Christmas time. I was very sick, did not have to go to the hospital. Then I went on the COVID MS registry and registered exactly what I had experienced. But it didn't even occur to me that 6 months later, I was still going to be having loss of smell and taste. I've lost a mountain of hair. So the question is, the COVID registry, how is it following people like me that thought they were over it, but 6 months later are having symptoms? And what should I do? Should I do anything to go back and try to change that?
I don't think the COVID MS registry was really set up to capture what you're experiencing. So it was more a snapshot in time to say, how many people with MS have gotten it? What were their initial outcomes? Recovered. I think the only thing that it really does is it does give you that click in there to say not recovered yet, but it really doesn't go into any great detail about what does that mean. Are you 2 weeks out? Are you 6 months out? So yeah, I hear you. I don't know of a mechanism we have yet from a registry standpoint to look at that, whether you have MS or not. And this, the whole concept of, the long haulers and lingering symptoms, which is, clearly affecting some people like yourself. I just don't know that we have a mechanism for collecting that data in the MS world yet.
Thank you.
Yeah.
And it looks like we have time for one more question. It comes from someone anonymous. They're wondering if they should still get the second Pfizer shot. They said they have had COVID and they received the first one and have been diagnosed with long COVID. Not sure what that is, but should they still get the second shot?
So the long COVID is kind of what just the previous call was. So these are people who have long-term symptoms after initial infection. In theory, and again, there's no hard data to back this up, you could say, okay, I generated a certain immune response when I had my initial COVID infection, and now I've gotten vaccination. So you could argue that a person who's had COVID and has had one dose of Pfizer or Moderna is kind of like people who've had two doses and no infection. So they got their initial priming of the immune pump with their infection, and now they've got a second round of immune stimulation. So there are people out there who would argue that people who had the infection could probably do with just one dose. Again, purely theoretical. And again, if you even put the prior infection of COVID aside, you can say, well, with one dose of Pfizer and Moderna, I'm in the 90% range for protection. Second dose, I'm in the 95% range. My gut would say someone who's had COVID and has done one dose probably is in the 95% range. By doing a second dose, do you increase that further? Do you get maybe the 97 or 98%? I don't know the answer to that. So yeah, I don't think it's totally crazy to say, okay, I'm going to stop with one dose of the vaccine.
It looks like we have 4 more questions, but I know you have to go. So would we be able to email these to you?
Sure, absolutely.
Okay,
absolutely.
Awesome. So we'll do that. I'm so sorry we ran out of time, guys. But if you did miss any part of this conference, it will be replayed on demand on MS Focus SoundCloud, msfocusradio.org, and the Multiple Sclerosis Foundation YouTube channel. And please be sure to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next Zoom conference will be on Tuesday, July 6th at 3:30 p.m. Eastern Time with Herb Kirkpatrick, whose topic is science-based approaches to exercise with MS. And we want to thank all attendees for participating. And if you have a moment, please take the survey. It's a brief survey to just, give us your feedback, how we did, what your experience was like, and we welcome it as always. And Dr. Thrower, again, thank you so much for your time, your extra time you shared with us. It was good to see you.
Good to see you. Thank you, everybody.